Bueno, bienvenidos a la segunda Masterclass de Oftalmo Córdoba 2021. En este caso tenemos el gran honor de presentar al doctor Lucio Buratto, que nos está visitando desde Italia. Para mí personalmente es una gran satisfacción estar con él acá. Es un gran cirujano conocido a nivel mundial, que ha escrito muchos libros, que de hecho hace unos días, aprovecho para agradecerle en vivo, me mandó una caja llena de todos sus libros de regalo a mi casa, que fue una gran satisfacción y un gran honor tenerlos. Así que bueno, bienvenido Lucio, muchas gracias por estar. Sabíamos que por tema de agenda a lo mejor él no iba a poder estar aquí hoy, así que la charla la tiene pregrabada, pero tenemos el gran honor de tenerlo acá en vivo con nosotros. Bienvenido Lucio.
Thank you so much. I really appreciate the invitation. And I saw part of the meeting today. I must congratulate with you and the organization. It was a very nice meeting.
Bueno, muchas gracias Lucio. Tenés 2-3 minutos para hablar acerca de tu congreso. Para que sepan, Lucio, como ya todos saben, él es el director de un gran congreso de oftalmología que se hace en Europa, que es conocido a nivel mundial. Así que, Lucio, invita un poco a la gente de acá de Argentina y de Latinoamérica que te esté escuchando para tu próximo evento, que es en unos días, ¿no?
Yes, since 41 years, I organize a congress called Video Catarata Refractiva now. And usually we organize this meeting in person. Since last 2 years, we do an online meeting. The meeting is mainly dedicated to cataract and refractive surgery. We use not formal presentation, but many videos, many clinical cases with a lot of discussion. Everything regarding the meeting is recorded in our platform called occhio.eu. In Occhio, you can find the whole meeting and the past meeting also. My meeting is very similar to Oftalmo Cordoba, in fact. We do live surgery, we do presentation, we do many clinical cases, we do a lot of discussion. We don't do, since last 2 years, real live surgery. We do pre-recorded surgery with discussion. In this way, we can find, I would say, better part of the surgery that are interesting for the audience. And we can discuss some specific part of the live surgery, not the entire live surgery. In my opinion, this is a nice way. And we received this year contributions since every country in the world. I mean, from Japan, from Brazil, from Canada, from Russia. And we had 40 contributors. And I like to receive clinical cases also from South America more and more, because I see that they are performing very nice surgery. Anyway, go to occhio.eu and you will find a lot of interesting material, also historical material, and contribution from many parts of the world.
Bueno, Lucio, bienvenido. Muchas gracias por tu presencia. Como ya les dije anteriormente, la presentación está pregrabada, pero el doctor Buratto se va a quedar luego para responder algunas preguntas que le va a hacer el doctor Noé Rivero, que está acá al lado mío. Yo tengo que salir para el quirófano, así que vamos a comenzar con la presentación del doctor Buratto y luego el doctor Rivero le va a hacer unas preguntas al doctor Buratto. Muchas gracias, Lucio, por tu presencia y nos vemos pronto. Saludos.
Okay, thanks so much. Surgery in presence of Faquicas oil.
Éxito.
Faquicas oil represents a valid surgical management for cases of high metropias, especially high myopia, and they are designed to stay in place for a long time, but not forever. Sooner or later, we have to explant those eye oil because of cataract, because of endothelial cell loss, because of inflammation, because of decentration, or for other reasons. When we want to explant a phakic IOL, we have to do first a very careful examination of the eye. We have to check the endothelial cell density. We have to check the anterior segment by using the anterior OCT and also the posterior OCT. We have also to do a very precise biometry because those patients are refractive patients and they are asking for a very precise refractive result after surgery. And also we have to examine the IOL, the material of the IOL, the size of the location of the IOL, and the relationship of the IOL with the internal structures. There are three kind of IOLs. Now we implant more and more posterior chamber IOL, but in the past we implanted several iris fixated lenses and some anterior chamber lenses. So when we have a cataract in presence of a phakic IOL, we might find different material, different location, different IOLs. The material of the iris really determines the entire procedure, especially the size, the number and location of the incision, if we do the cataract surgery through one incision or two incisions, and they generally influencing the whole procedure itself. When we are ready to explant a phakic IOL, we have to really free the lens inside the anterior chamber. If it is an iris fixated lens, we have to disenclavate the IOL. If it is in the anterior chamber, we have to rotate the lens to see if there are adhesions, angular synechia, or any other problem. If the lens is in the posterior chamber, we have to dislocate partially or totally inside the anterior chamber. Generally speaking, if we have a hard lens, we have to do a large incision. And if we have a soft lens, we can do a much smaller incision. Let me show a case of anterior chamber IOL explantation. This lens is damaging the anterior segment. 1 foot is inside the iridectomy. There is a cataract, and we have to do a large incision to removing the lens. But if we use a good viscoelastic, the procedure is not so traumatic for the eye. When we plan to do cataract surgery in presence of a phakic IOL, we can use or not use the femtolaser. There are some advantages and disadvantages on using it or not using it. Let me now consider the standard phaco, I mean without the use of femtosecond laser. The phaco can be done through one incision or through two incisions. If we do that, we have to suture the main incision that we used for the IOL explantation. Let me now show a case of a phacoemulsification after having explanted a rigid IOL. You can see that there are a lot of fluctuation inside the anterior chamber. There is a lot of loss of fluid, and the anterior chamber is deepening and flattening, and this is not safe, it is not good for the surgery, and it is not a nice procedure. If we explant and we suture the main incision, we can do phacoemulsification through a standard incision, and it's just a regular phacoemulsification, just much easier, much more controlled by the surgeon. If we want to explant a soft IOL, we first have to disenclavate if it is an iris fixated IOL. If it is in the anterior chamber, we have to release the adhesions to the eye. And if we have the lens in the posterior chamber, we have to partially or totally dislocate it into the anterior chamber. There are three ways to remove the IOL from inside the eye. We can remove entire the IOL, we can cut the IOL, or we can fold the IOL. They are all three procedures, they are good. Let me show a case of explantation of an old model of ICL. I'm explanting the entire IOL. I'm using the same incision I used for implantation, but it is a little bit larger. And I use two forceps to remove the IOL, trying to keep the incision smaller as possible. In this case, I'm cutting the IOL. It's very important to use a good viscoelastic to keep the IOL away from the anterior capsule, away from the endothelium, and it's important to avoid touching both of them. And you can remove the IOL through a small incision. There is another way to remove an IOL is by folding it inside the anterior chamber. It's necessary to also a good viscoelastic, keeping spaces and not leaving the anterior chamber. And it's necessary to have a good forceps and a spatula. And the procedure itself is easy and very efficient. Let me now talk about the option of using a femtosecond laser during cataract surgery in presence of a phakic IOL. There are 3 steps on that procedure: femtolaser treatment, phakic IOL implantation, phaco plus IOL implantation. Using the femtosecond laser in presence of a phakic IOL is not so easy because there is the optical disc. The optical disc is small and the thickness is increasing from the center to the periphery myopia, or there is a decentration of the optical disc, or there is an angle kappa, or there is a pupil decentration, there is something. So the femtolaser treatment can be more complicated. Especially the capsulotomy is the critical phase of the femtolaser treatment. In this case, we have a well-centered IOL and the capsulotomy can be well-centered. In this case, the IOL is decentered and the capsulotomy can be incomplete. In this case, the IOL is decentered, and when we perform the capsulotomy, it will go partially through the optical disc, partially outside. Same is happening with a different laser and different patient. So let me show you what might happen when we do laser treatment in the center IOL. The laser is going partially through the IOL and partially outside, so the capsulotomy can be incomplete. Another problem when we use the femtosecond laser is the pattern that we use. If we use a cube pattern, we have a lot of material that is limiting our visibility on the anterior capsule, or sometimes there is gas. So anyway, there is a problem in seeing the capsulotomy. If we use a quadrant technique, it's much easier to see the capsulotomy, and there is much less gas, much less material, and if there is some gas, we can just inject some viscoelastic and free the anterior chamber from the gas. So the problem with the femtosecond that there is a reduced visibility in the anterior chamber due to presence of gas and clouding of lenticular material. And also there is a little space inside because there is an IOL, and when we try to explant the lens, we might affect the capsulotomy, and this is a problem. If we have gas or if we don't see, we have to inject viscoelastic or trypan blue. There are several advantages on using the femtosecond laser. The users, they know exactly what I mean when I say that, but there are also some problems when we use the femtosecond laser. Especially in presence of a phakic IOL, there is a possible interference between the phakic IOL and the femtolaser OCT, and this can generate inaccurate and incorrect automatic recognition of the ocular structures. And this can be a problem. In this case, for example, we have the laser not recognizing the limbus, so the capsulotomy can be wrong. In the other case, we have the laser that is not recognizing the pupil diameter, the pupil center, so when we do the capsulotomy, it can be decentered. The other one, we have the laser not recognizing the posterior surface of the cornea. So if we treat inside the eye with the laser is not doing a good job. In the other case, we have the laser recognizing the anterior surface of the eye instead of recognizing the anterior surface of the cataract. So if we do the treatment inside the nucleus, it can be also wrong or damaging the intraocular structures. So in fact, when we use the femtosecond laser, we might have some optical effects that are changing our parameters during the laser treatment. So in fact, the use of femtolaser treatment in presence of phakic IOL is more critical, especially capsulotomy might be incomplete or have hemorrhage, and if it is incomplete, when we extract the IOL, when we remove the IOL, we might damage the capsulotomy itself. In this case, we have a well-centered IOL, and the capsulotomy was also well-centered in the IOL, and this is the final result after cataract surgery. So, in fact, there are no doubts that the use of femtosecond laser in cataract surgery in presence of phakic IOL is much more complex than a standard phaco. In conclusion, two incisions allow better control of the entire procedure with both rigid and soft IOL, with or without the use of femtosecond laser. And in both cases, it's very important to use an appropriate viscoelastic able to keep the space very deep and not to leave the anterior chamber during the procedure. And phakic IOL explantation plus the use of femtosecond laser must be carefully evaluated, case by case, and performed by an expert surgeon who is an experienced femtosecond laser user, especially accustomed to adjusting settings during the laser treatment. Standard phaco is generally safer and easier when we have to explant a phakic IOL and perform a cataract surgery. Thank you very much for listening to me. Thank you so much.
Muchas gracias, Lucio.
I'm talking about cataract surgery.
¿Cómo estás, Lucio? Soy el doctor Noé Rivero. Un gusto saludarte y felicitaciones por la presentación. La verdad que muy prolija y diste muchos tips. Una pregunta, como bien dijiste, son pacientes muy exigentes y que esperan un resultado refractivo en hemetropía. ¿Qué fórmula o qué tienen que tener en cuidado para que el biómetro no te confunda los picos reales del cristalino con de la lente intraocular? Esto te puede llegar a cambiar la profundidad de la cámara anterior y puede llegar, según la fórmula que utilices, darte algún error refractivo postquirúrgico. ¿Qué tomás en cuenta o qué fórmula utilizás? O medí la cámara anterior con un ultrasonido en forma manual para uno tener bien en claro cuál es esa profundidad de cámara anterior.
So if you have the preoperative biometry, it can help you in planning the refraction after surgery. But if you use a modern machine like the YoMaster 7000, you can have very precise biometry because this instrument is very, very, very precise. And you can do a very good calculation for the IOL. Generally speaking, I prefer to plan a slight myopia, let me say -1, -1.5, to be sure that I remain a little bit myopic than going to hyperopic. Mainly, I use the Barrett or the IGS formula. The Barrett is the most used formula. I must say that we didn't have many unexpected refraction after this kind of surgery. They are high myopes because if they receive a phakic IOL, it's because they are high myope. So all the high myopes might have some retinal problem, etc., etc. But I'm quite happy with the results I have with the calculations.
Excelente. Y me imagino que también uno le avisa al paciente de que puede haber un error refractivo y que haya que hacer una corrección posterior. Otra pregunta es en pacientes que tienen un bajo recuento endotelial. y tienen una lente de cámara anterior, tipo Artisan, Artiflex. Está en la literatura, algunos dicen que hay que hacer la faco, dejar el lente donde está para que proteja el endotelio. ¿Usted tiene experiencia con esa técnica? ¿La recomendaría?
Yeah, sometimes it might happen that you have a very bad endothelium, and I use a very protective viscoelastic. I try to do a very soft surgery, and if I see after the surgery that the cornea is not clear enough, I ask the patient to receive endothelial transplant. I mean, it might happen, very rarely, but it might happen. We try to do the surgery before having so bad endothelium.
Bien, y una última pregunta. En estos pacientes, ¿prefiere una lente monofocal, asegurarse una buena visión de lejos sin distorsiones, o también le ofrece al paciente lentes multifocales?
Most of the cases we implant monofocal IOLs because the multifocal things like myopia, they're not all the time available, but most of the myopic patients have some retinal dystrophy or some retinal problems, and the multifocal, they don't give a really good quality vision. The multifocal have their own some quality vision problems, etc. If you add the retinal problem of the myope, it can be not very, very nice result.
Perfecto. Bueno, muchísimas gracias, doctor Buratto.
I
Un placer.
want to first give you the address of Okio, if you like to go.
Perfecto. Puedes ir a okio.eu.
Thank you so much
Bien.
for inviting me.
Muchas gracias, un placer haberlo tenido en esta masterclass, en esta edición de Oftalmocórdoba, y ojalá nos pueda acompañar en próximas ediciones y que su congreso sea un éxito. En un ratito más vamos a seguir con nuestra conferencia magistral, que como año tras año la da el doctor.
Have a nice evening and a nice weekend.
Muchas gracias, doctor Buratto. Vamos a seguir con nuestra conferencia magistral que la va a dar el doctor Luis Scaff. En unos minutitos más estaremos nuevamente juntos.